Here I am back, continuing on with the second part of the presentation. Welcome back. I'm going to review what some of the things I had presented before. Out of the 48 persons selected for molecular analysis, in 24 of them we have found mutations in collagen 2, and in 4 of them in collagen 11. So most of these were what we call stop codons, meaning that the transcription is truncated early and no functional protein is made from the mutant strand. And same for splice site mutations. So they lead to a short protein that doesn't get incorporated into the trimer. So the major mechanism for the syndrome does appear to be what we call haploinsufficiency, meaning there is not enough of the collagen to produce to be laid out into the extracellular matrix, which is the area between the cells. So very few mutations were such that they actually distort the structure of collagen. So this opens it up to the possibility that we could potentially treat Stickler syndrome by increasing the amount of collagen produced from the normal copy of the gene. Given that there is a normal copy in each of the affected individuals in addition to the mutated copy. So how would we go about that? We'll be doing the testing from the fibroblast lines, which are taken from the skin biopsies from affected individuals, either from surgical samples or skin biopsies we have taken at the NIH. So the first step is to determine the normal amount of collagen found first in normal samples and then from Stickler syndrome patient samples, and stain them using antibodies to see if we can quantitatively localize them. So the goal of this is that once we treat the cell lines with compounds that we think are going to increase the amount of collagen 2 produced, we can compare the quantity of collagen before and after treatment. So the green stain you see is the fibrillar network that holds the cells in suspension and forms the connective tissue. So there are already some drugs that are known or suspected to increase the production of collagen. Vitamin C cross-links the collagen fibers, so it is thought to stabilize and increase the amount of collagen that's being laid down. And also there are some drugs called ARBs and calcium channel blockers that are used for blood pressure control, and they are hypothesized to increase production of collagen as well. So the next thing to do is test these compounds on our fibroblast lines to see if we can actually increase the amount of collagen without having toxic effects or other unpredicted detrimental effects on the cells. This is why the tissue samples and the skin all of you have contributed. They are so important for this research to have any progress. And I do encourage you to participate and continue to send us samples. I'm then going to go on to describe a few of the clinical findings that we are looking at the NIH. So I mentioned earlier that Stickler syndrome persons are usually taller than average. When we look at our data, we find that persons with collagen 2 mutations are taller than about 60% of the average population, whereas the persons with collagen 11 mutations are actually short. They fall in the lowest 10% of the population in terms of their height. So an issue has come up with some of the children that are very short, that should they be getting the growth hormone, and we have not recommended that because there is no evidence that it could be effective. We are really watching them really closely to see if they are going to attain average height. Additional features we're looking at are the presence of aortic root dilatation in 4 of the families with collagen 2 mutations. And also another unusual family where all the affected members have elevated white cell counts. And this was found in all of the persons who did have Stickler syndrome in that family. But the good news is there is no aorta-related deaths in those families, and the elevated white cells have not led to any shortened life expectancy in the family affected either. We do have a new cool toy, which is our new 3T MRI at the NIA, which is dedicated for research, and we are using that to investigate orthopedic features and other skeletal features, joint problems in Stickler syndrome, and I think that will also be a really valuable contribution. I want to bring up a new idea that we've been looking at. This has actually emerged out of my participation in the Stickler involved people meetings in the past, and I often get asked why in some families the new generation is always more affected and more severely affected than the older generation. So up to this point we've never had an adequate explanation for this, and when I was asked I could never come up with a genetic mechanism or that could be explained. So a recent paper in the literature, which is a completely unrelated paper, suggested that there could be imprinting going on with the collagen genes. What does that mean? That means that the copy of the gene inherited from the mom and dad function differently in one's body. So for example, the copy of the gene that is inherited from the dad is preferentially inactive in the cells, and the one inherited from the mom is the one that is producing most of the collagen of interest. So this hypothesis, if it's true, may explain some of the differences of severity between generations within a family. So for example, if the maternal gene is the active one, if a woman inherits a copy of the mutation from her dad, she may be mildly affected herself. That will be because the copy she inherited from her own mom is active and compensating for the defective copy. However, when she has children and they inherit the mutation, their maternal copy, meaning the copy with the mutation, would be the more active gene, therefore they could have more severe manifestations. We are actively investigating this hypothesis, looking at family histories and tissue samples in our study. So why participate at the NIH study? You may not be able to get any benefit yourselves, but it is entirely possible that your children may benefit or other persons who are affected may benefit. I know it's not possible for everybody to come out to Baltimore. We do try to help with travel expenses through Mercy Medical or through Angel Flights. I do want to say that there is no cost to having the actual tests done, and you don't have to pay for lodging, but I do realize that traveling to NIH is not possible for many of you. I also want to add that most physicians out there see only a few Stickler syndrome patients, and they don't develop the collective information one can develop from seeing a large number of patients over a period of time. So the clinical information obtained from the NIH clinic as well as the clinic with Dr. Lieberfarb in Boston is really critical for us to understand the natural history of the syndrome better and to be able to counsel the families more effectively. I have many people to thank, including all the participants who have contributed and Stickler involved people for giving me the opportunity. Dr. Franco Mano, who started the study coordinator, and all our staff who participate and contribute, as well as all our scientific contributors, including the ones from Bethesda and those who are currently working at the NIA. So thank you very much again. Thank you for listening, and I hope I can make it to the next year's Stickler Involved People meeting. I look forward to it, and I hope to hear from all of you about the study. And on the next slide, you see some information about the study, the website, and the contact information for myself and the study coordinator. Thank you again.